This is all bread and butter sort of procedures. They're things that are done virtually every day, and these are our neurosurgical procedures and bedside emergencies, as well as how to do them. I have nothing to disclose. The planner and the CME committee have nothing to disclose. In these sorts of cases, we need to be culturally competent, as language barriers as well as certain innate beliefs in the patients can contribute to difficulties in getting some of these procedures done in emergent settings. Now, as with any operative or invasive procedure, there's a pre-procedure checklist that needs to be followed pretty religiously. In any invasive procedure where there is a potential for bleeding, you need to know the patient's PT, PTT, INR, and platelet counts. These will prevent certain disasters from happening in the case of the surgery. Certainly, it won't get rid of all your disasters, but you want to dot your I's and cross your T's and make sure that you can avoid disasters as possible. Check the chart for the consent. If you don't have a consent and you do the procedure, you've committed battery. Don't do that. You want to review all the relevant films. In most cases, if you walk like a duck and talks like a duck, it's a duck. But in some cases, the anatomy will be skewed. The things that should be where they're supposed to be aren't. And you need to know those things going in. And that dovetails with the next point: planning, planning, and planning. You want to make sure you have all the equipment necessary for the procedure that you plan to do. If it's an EVD, you want to have the drill, the EVD kit, the lidocaine, which for some reason at most of our hospitals is fairly difficult to obtain in a timely manner, etc. You want to visualize the things that can go wrong during the procedure and what you need to correct it. So in most of these procedures, these are relatively quick in and outs for the experienced practitioner, but even still, things can and have wrong. You want to position the room and the patient and the equipment to your comfort. Now, the way I do the procedure may be different than the way Dr. Carson does the procedure or than the way Dr. Mealy does the procedure, but because I'll be doing the procedure, or whatever the case may be, Dr. Carson doing the procedure, you want you or he or Dr. Carson or whoever else want to have the room and the patient and the equipment set up the way that's most conducive to his doing the procedure or her doing the procedure. And of course, sterility is key. Chloroprep, Duraprep, betadine, those are all inexpensive things. However, infection and the sequelae of the infection are very expensive to manage and treat. Now, style points, you've all heard that no matter how elegant of a surgery you do, the only thing the patient is going to care about afterward is how their wound looks, because they're not going to know the 18 hours of surgery to correct some huge deformity. What they're going to see is your wound closure. So their families, their nursing staff, and the patients themselves are going to be able, or should be able rather, to look at the patient after a procedure and not realize that they had a big major invasive procedure. And yes, an EVD is a big major invasive procedure. You're putting in a foreign body directly into the brain. So make sure you clean up the patient, clean up all the blood, and clean up all your equipment. Don't leave the patient's head orange from the Duraprep, for example, is a simple thing. And all of these things will improve with practice. Now let's dive right into the meat of the matter. There are several skull landmark points for these invasive catheters. There's Fraser's point, which is a posterior point there, 3 to 4 centimeters off midline and 6 centimeters above the inion. For a posterior approach, and we'll talk about why we do each of these a little bit later. There's Coker's point, which is the most common EVD location for us, and you can do this right or left-sided. Most of the time you do it right-sided, reason being that the left side potentially has more complications associated with it. And this is 1 centimeter anterior to the coronal suture in the mid-pupillary line, and we'll talk about practical finding that point a little bit later. And then also, there's Keen's point, which is another posterior landmark point for passing the catheter. And in this case, it's 3 centimeters above and 3 centimeters posterior to the top of the pinna. There's also Dandy's point, but unfortunately I couldn't find a really nice image of that, so I'll talk about that in words. Now, Fraser's point. As mentioned previously, this is 6 to 7 centimeters superior to the inion and 3 to 4 centimeters lateral. The trajectory when you pass a catheter here is toward the contralateral medial canthus of the eye, and you want to pass the catheter parallel to the skull base. And there's a particular reason for that. You insert the catheter 6 centimeters with a hard pass, meaning with the stylet still in place. Then you remove the stylet and soft pass another 6 centimeters. course, you want to verify on imaging first that you have this amount of distance to put the catheter in. And the reason for this type of approach is to cannulate the length of the lateral ventricle. Additionally, in certain extreme cases where you need more than one ventric for particular reason, maybe there's something blocking the communication between the two ventricles or some other pathology, you would use potentially a posterior approach or a left-sided frontal EVD or whatnot. Now, Coker's point. This is your bread and butter EVD point. 12.5 centimeters, it says superior, but it's really posterior to nasion along the convexity of the skull, and 3 centimeters lateral. And now this practically will place you 1 centimeter anterior to the coronal suture in the mid-pupillary line. Now, with that said, all heads have a certain degree of variability. And several of you were with me at Arrowhead when we saw the patient who jumped out of a car. And I don't know if you guys remember the cartoon Hey Arnold, but after his trauma, he had that Hey Arnold football-shaped head. And so these EVD landmarks were really not sufficient to place the EVD, and we ended up having to image him after the initial attempt and then fix based on the imaging. Now, the trajectory when you place through Coker's point is toward the ipsilateral medial canthus and the external auditory meatus. And from there, you triangulate where your tip of the catheter should go. And the distance to pass the catheter is 5 to 6 centimeters. Now, if you're passing the catheter to 5 to 6 centimeters and you're not getting a return of CSF at all, you should evaluate your trajectory, because the likelihood is, unless there's some deformity of the anatomy inside the skull, that you've passed the catheter in an inappropriate trajectory. Now, Dandy's point is located, it's another posterior point. It's located 3 centimeters superior to the inion and 2 centimeters lateral. I've never seen this done myself. I don't know, the more senior people, if you've seen a Dandy's point EVD done. But it's one that is prone to damaging the visual pathway, and so it's avoided unless it's absolutely necessary. Keen's point is the point 3 centimeters superior and 3 centimeters posterior to the top of the pinna. And in this case, your trajectory is, again, the ipsilateral medial canthus and parallel to the skull base. And the trajectory is the same as we mentioned previously for the posterior approach. You insert the catheter 6 centimeters hard pass, remove the stylet, and pass another 6 centimeters soft passing. And the idea here is, again, to cannulate the length of the lateral ventricle. Now, the ventriculostomy itself. Let's get to the heart of the matter. With a ventriculostomy, you always follow your procedural musts. These are checking your coags, making sure the patient is stable for the procedure, making sure you have all your equipment, making sure your consent is on board, do your timeout, etc. Now, assuming we're going to Coker's point, you measure Coker's point twice, then mark. You use surgical clippers to remove the hair, never shave, clip. You remeasure Coker's point again. Prep the skin with betadine, DuraPrep, or whatever else. Now, with any invasive procedure where you will be violating Dura, you want to avoid ChloraPrep. Then, of course, prepare your room and open your equipment, don your sterile gown and gloves, drape the patient, and remeasure Coker's point. And if you want to, you can remeasure Coker's point again, just for good measure. Then you draw lidocaine. We use 1% lidocaine with epinephrine.
So where are the landmarks for a Coker's point? You know, you said you are absolutely right. You should continue to measure. Where are the landmarks?
We measured it, or mentioned it a little bit earlier in the talk. It's 12.5 centimeters posterior to nasion and 3 centimeters lateral to that point in the mid-pupillary line, which places you approximately 1 centimeter anterior to the coronal suture.
So 1 centimeter anterior to the coronal suture, mid-pupillary line.
Yes, sir.
Right. That's how you verify time and time again.
Right.
And you're aiming, you said, towards the medial canthus and what?
And the external auditory meatus.
1 centimeter in front of the external.
Okay.
1 centimeter in front of that.
Okay, 1 centimeter anterior to the external auditory meatus. Okay.
So measure, yes, but confirm also, because everybody's head might be a different size. Okay. So if you measure and you're 4.5 centimeters posterior to the coronal suture, where are you placing it?
You're placing it in the motor cortex.
In the motor, correct, right? So it's not always about the measurements. You have to confirm. So I know you just said 3 times you want to measure, but 3 times you want to confirm.
Right.
With anatomical.
So once we've confirmed the appropriate location of Coker's point, then you draw lidocaine into the syringe that you've prepared, a sterile syringe, and we typically use 1% lidocaine with epinephrine. And you create a skin wheel down to bone, infiltrating as you go through, drawing back to ensure that you don't penetrate any vasculature. And then you anesthetize the tunneling site, the direction in which you plan to tunnel your trocar. You then take your scalpel blade and make a vertical incision plunging all the way to bone. And you scrape the periosteum off of the calvarium, either with the back end of a forceps, and I'm not sure why my sentence cut off there, or with the blade of the scalpel. For my own comfort, I prefer to use the back of the forceps. Then you use a hand twist drill in placement orthogonal to the skull, following the trajectory that we discussed earlier. And you use the forceps again to remove the bone fragments. Then you use a smaller scalpel blade to create a puncture incision through the dura. And you confirm dural penetration with any of these instruments, the brain needle back into the trocar, or the Allen key that's included with your twist drill kit. Next, stop and breathe. This is key. As a matter of fact, most of you guys have been to Kaiser already. Jonathan Negus over there has a nice little aphorism that he says at this point. He says, God, I know you and I have had our differences, but this is neither the time nor the place to take this out on this poor patient. And then he proceeds with his procedure. So at this point, you place the tip of the EVD into the hole that you've created. And I apologize, that should say twist drill hole, not burr hole. And you pause to aim here. Again, oftentimes these procedures are done sort of under duress in a patient who is not doing well, but you need to make sure that everything is done correctly. And so it is okay to take a second or 2 or 3, maybe not a minute and a half, but a few seconds to pause and aim and figure out that you're doing everything correctly. And here, your knowledge of the CT pre-procedure is key. You want to make sure that you know whether the patient has hydrocephalus, any mass lesions or midline shift that might affect your planned trajectory, slit ventricles that'll be more difficult to hit and maybe off center or somewhere else, any underlying intraparenchymal or intracerebral hemorrhages, or any underlying epidural or subdural hematomas. So assuming that you found your trajectory, you pass your EVD hard pass 5 to 6 centimeters. And as I mentioned previously, if you have no return of CSF at 6, you're most likely in the wrong place. You should remove the EVD and re-aim. Also, at this point, it's a good idea to clean off the EVD catheter, as most likely you will have some sort of detritus in the fenestrations of the catheter. Again, hold the catheter, re-aim, replace the catheter. Yes, sir.
What I was going to say was,
stapled to the skin. And the purpose of it is, in a sense, to patient-proof and nurse-proof your catheter, because the patient will move, the nurses will transfer, turn, clean the patient, and the outcome of that catheter getting ripped out of the skull, in particular when it's connected to a drainage system, can be catastrophic. So it's very, very important, like Dr. Muley had pointed out, to make your tension relieving coil and to make it well and to make sure it's secure. So once that's all done, you place your biopatch, which is again an infection prevention measure. Place your tegaderm covering your entire system at the skin. And then after all that is done, you hook up your EVD to the drainage system. Then the next most important step is to check your pupils. You want to make sure that if a pupil was sluggish before, it's more reactive after you've created this drainage outflow. And you also want to make sure that you haven't created a blown pupil by your procedure. Now, variations and pearls associated with this procedure. If you feel resistance when you're inserting your EVD, stop, and if that resistance is just inside the inner table, you want to check for dural integrity. It's possible that even though you think you've penetrated the dura with your cruciate incision, you may not have enough length on your scalpel blade to penetrate the dura, depending on the anatomy inside the inner table. If you feel resistance further in the insertion, you may be inserting it in the wrong trajectory, and you may be hitting some piece of anatomy that you're not trying to, or it may just be that the brain itself is under tension. So, yes.
So I just want to reiterate what Dr. Krell said about once you're inserting it and you're only inserting it, let's say a centimeter, you have difficulty, you are hitting dura. You should not continue to push on the dura because absolutely you will get an epidural hematoma. And this counts no matter if you're putting in an EVD or a subdural drain. So you keep on hitting the dura, keep on bouncing up, you will get an epidural hematoma. And then you took a procedure that has little morbidity and mortality and you increased it. Okay? So we don't want to eat that 10% that has an issue and 4 to 5% that needs to go to the operating room after the procedure. So don't bounce off that dura.
Another pearl that comes from experience is make sure you set up your stopcock before you start the procedure. Place the yellow cap on the stopcock when you're setting up, so that way you don't lose any CSF as you're assembling your system. Also, the trocar insertion and tunneling itself may disrupt the depth of your EVD. You may have done a beautiful insertion, placed your EVD into the foramen of Monroe at 6 centimeters, everything flows perfectly, and then you tunnel your trocar, and just enough, you've pulled out your catheter or put it in further as you're tunneling. Yes, sir.
The way that happens is, especially if your incision isn't big enough. So you're going in, and then you have to tunnel the trocar. As you're tunneling the trocar, it's rubbing up against the catheter that's going in. It will either push it in or pull it out as you move that trocar underneath the skin. So make sure that the incision is big enough. Not too big, not big, just big enough. Because that's the #1 way of displacing the ventricular catheter that goes into the ventricle. The other thing that you can do with the trocar, if the incision is not big enough, is that tip of that trocar is very, very sharp. So you can actually cut the catheter when you put it in. So be careful of all those. The easiest way to do it is just to make the incision.
One other comment that I will make is
Dr. Wacker, Dr. Wacker, I'm sorry. Could you talk into the microphone?
One other comment that I will make, I don't know whether this was already commented, but one needs to reconfirm anatomy before you start, right? After you're great, before you start the procedure. I have more than once seen people get into trouble because they didn't do that step. And they didn't feel for where the nose is. The nose you can always feel. You can always feel the bridge of the nose. You can always get kind of oriented there. And if you don't reconfirm your anatomy, you can get really, really lost and do really bad things.
big scalp hematoma. And again, your body won't hit the top of the
I'm sorry, one more time.
if you have a big scalp hematoma, say it's a problem, and you're trying to get down to the dirt and get your artery, but it won't reach.
You can sort of improvise in a case like that and use your brain needle to penetrate the dura in that case. Or the trocar, yeah. But if you do use the trocar, again, remember that the trocar is extremely sharp and you don't want to be lacerating brain when you go in.
Same thing, just like Dr. Ryan just mentioned. Always have to remember where you're going. Bone here is a lot thinner than if you're going back. And you know sometimes you have to go back here. You run out of places to put your unit, so you have to go back and do a flex and go. So you may drill, and you're not getting all the way down. So just remember your bone.
Anybody else at this point?
Yeah, like that.
Really?
That's good. Something that I think also helpful is that if you actually pass the trocar prior to attaching it to the catheter, partially through the skin, so it's coming out of the skin, and just attach the catheter to the end of the trocar after you've already passed it to the skin. That way you don't risk pulling it out where you're trying to jam it through your skin.
Yeah, that's actually the last sentence on the slide there is exactly that. So it's again, it's sort of stylistic variability. Not everybody will be comfortable with that. It just so happens that a lot of these procedures I learned from either Dr. Dallin or Dr. Carson. So I sort of tend to do things the way that those two do, and so I've done that before as well. Now another thing you can do is sort of, if you'll pardon the pun, a rule of thumb. Is you can measure the length of your index finger and your thumb, and that in many cases can approximate your 12.5 and 3 centimeters. So you can at least get a general sense of where your location of Coker's point is. Post-op orders, generally speaking. Yes, sir.
It's more important to know the anatomical landmarks.
Yes.
Okay. You can get there using those. It's more important to know the anatomical landmarks, and you can get there using the measurements, but people's skulls are different sizes.
Right.
So you 100% want to know where the coronal suture is, feel it, go a centimeter in front of that, and the mid-pupillary line.
Right, which again goes back to always verify everything a million times whenever you're doing anything.
And especially here with kids.
So your post-op orders for EVDs, and these are general post-op orders. There will be some esoteric cases where there will be some variance with this. But generally speaking, you want your EVD at 6 millimeters of mercury. If it's a ruptured aneurysm, you want your EVD a little bit higher at 15 millimeters of mercury. Reason being, you don't want to risk re-rupturing the aneurysm by creating essentially suction inside the brain. Anytime you place any indwelling catheters into neural space, you want to start a prophylactic antibiotic. Traditionally, we use Ancef 1 gram IV Q8, and there is some variability with this, provided maybe the patient is penallergic or something like that. You can use a different antibiotic, and then you send the patient for a stat head CT to verify placement. Even if by the function of the catheter, you yourself are sure, you need to prove that that catheter is in the right place. Yes, sir.
What do you mean by put it at 15 millimeters of mercury?
Okay.
And specifically, you said to create suction inside of the cranium. What? It's not really that. What do you read?
So I misspoke. Thank you for correcting me. When you have the EVD, let me start at the beginning of your question. The level of your EVD is relative to the level of the transducer at the level of the external auditory meatus. So that transducer is your reference point in terms of height of EVD. Now, when we say the EVD is at 6 millimeters of mercury, we mean that the drainage system is at 6 millimeters above the transducer, which is at the level of the external auditory meatus. 15 millimeters means the same thing, but at 15 millimeters of height above the transducer.
15 millimeters of mercury.
Yes. Yes, 15 millimeters of mercury of height above the transducer, and those are delineated on the EVD drains. Now, the majority of our rotation sites, we use millimeters of mercury. Some rotation sites prefer centimeters of water. Both of those are delineated on the drain itself.
So all of our sites use millimeters of mercury.
Okay. All of our sites use millimeters of mercury.
That we rotate it.
Okay. And the measurements are delineated on the body of the drainage system itself. And of course, in cases like this, you need to be specific with your orders. So make sure that you state in your order that you're talking about millimeters of mercury, so that there's no confusion as to which measurement system you're using. Now, to address the other part of the question, you have the system creates a siphon effect of fluid, and that's how the fluid comes out depending on the height relative to your intracranial pressure. So with a ruptured aneurysm, you don't want to, yes?
So the whole purpose of the ventricular catheter is to equilibrate the intracranial pressure with the level that the ventricular catheter is set at.
Right.
So if you drain appropriately and it's set at 6 millimeters of mercury, you're then assume that the intracranial pressure is
greater than
6 millimeters of mercury or less.
Okay.
If you set it at 15, you then assume that the intracranial pressure and it equilibrates and it's no longer draining. It equilibrates. Then you assume that the intracranial pressure is 15 millimeters of mercury or less. There's no more fluid is coming out. The ICP was higher, then more fluid will come out, right? So if no fluid is draining, then you equilibrate at 6 or 15 or some other number, whatever number you use, millimeters of mercury. So when you set it and it stops draining, that's what you think the intracranial pressure is at that point. All right, go.
Okay. You know, from the physiology side of things, you also want to control cerebral blood flow and cerebral perfusion. And in a case like an aneurysm where you would want to have some you know, cerebral perfusion, you don't want the ICP to drop too low. And again, you keep your EVD at 15.
Anybody want to answer? What do you mean, what did he say? Read that, say that again. Come on, everybody pay attention to what he just said.
So what I said is that your cerebral perfusion, to some degree, is...
Wait, you're keeping it at 15 millimeters of mercury in a ruptured aneurysm because?
Because you want to control the cerebral perfusion.
Wait, no, the answer is no. Are you going to tell us the right answer? No, forget this. No, just tell us. Just tell us.
If you drop it too much, and you drain all the CSF into your ICP, this aneurysm is not secure.
It will re-rupture.
You have space around it, just like that.
What is the actual term?
Tamponade. It's tamponade.
Does anybody know the answer? The transmural pressure. So you have here, can I have this back? So this is really, really important. Why do we do these things? We need to know the pathophysiology behind what we do. If the pressure inside of the head is at 6 millimeters of mercury, and you still have flow into the aneurysm itself of blood, then and you have nothing on the outside tamponading it. So that part of it is true. That you have a change in the transmural pressure, and that change in the transmural pressure might be great enough, meaning the ICP is low enough, that you actually have rupture of the aneurysm again. So we tend to keep it up. Some people actually keep it 20 or more, right, when you first put it in. The vast majority of people keep it up, and you might want to lower it over time, maybe. But that's up to the individual. But that's why you don't lower it too much, because you create a difference in the transmural pressure, and you increase the risk of rupturing the aneurysm.
stay, which is the pressure down. That is the reason why you want it at least 15 or higher. But it's also the reason why any patient, you guys call me from England, first thing you guys ask me, let's put a central line. You don't want to be doing a patient that's not having secure. You know what I'm saying? So even if they're intubated, let's say a sick of argument there again. They're intubated, otherwise stable, but they have a ruptured aneurysm that has not either surgery or coiling, whatever the case may be. And unless it's an emergency, but otherwise, you don't want to try to stick Foley's in those patients. You want to try to put daylight in, obviously, glucose monitor, put central lines in, put EVDs unless they medically necessary to want because of this transmission pressure. That's the problem. Any sort of agitation, you know, if you're putting up Foley in, what's going to happen? You're going to increase the pelvic pressure, you're going to increase the abdominal pressure, you're going to increase the chest cavity pressure, and then the patient's going to butt do something. Why do I ask those patients, when I'm doing those cases, what do I tell the I don't want the patient bucking all that increased pressure to when they rupture. Yeah, you guys got to keep that in mind. It comes to secure and unsecured. And once they're secure, have at lines, whatever it is, right? Or at the very least, when we're in the point of control the end. So if Dr. Muley's taking one in for flipping, I'm doing that clearly, and we're going to start doing stuff, and if we're going to attempt to secure the aneurysm, then yes, but maybe not overnight. Again, to structure, especially if they have a lot of blood or tissue rate. It's just a good thing to keep in mind. I know we're talking about the EVD itself, which is general. Think about this intervention.
So another indication for doing an EVD is to give intrathecal medications. Examples that we've done are TPA for clot resolution and intraventricular hemorrhage, antibiotics for meningitis or ventriculitis, or chemotherapeutics for cancer. And you can actually administer these either via ventricular catheter or lumbar drain. We'll get to lumbar drains a little bit later. Now, intrathecal medication administration, like any manipulation of an indwelling neural catheter, is a sterile procedure, and there's no question about the sterility of this procedure. In fact, the incidence of ventriculitis is correlated with unsterile manipulation of the drainage system. So anything that you do to this system, including drawing CSF Monday, Wednesday, Friday like we do, or trying to flush the catheter if it gets clogged or anything, must be done under sterile conditions, and in particular med administration where you're directly placing something into the neural system. You want to make sure it's done sterilely. Yes, sir. Okay. Now, in some literature, they suggest actually sterile gloves and draping the access port to give the medication. And you remove the cap from the access port and apply either ChloraPrep or alcohol. You connect the syringe and draw back 2 to 3 milliliters of CSF. And the reason for this is to ensure that you have space to administer your 2 to 3 milliliters of medication without increasing the intracranial pressure by adding fluid to a closed space. Then you connect your syringe with your drug, push your drug. Depending on which drug, there's a different push rate. Yes, sir.
Sorry. So two parts of this. First of all, this is so important that you do this under sterile conditions. And when you first put in the ventricular catheter, you need to do it under sterile conditions, right? You need to put on a hat, a mask, a gown, gloves. You should put on the 3/4 sheet, appropriate draping off of the head as well. And you are absolutely right. The amount of sterile draping is proportional to the amount of catheter and ventriculitis. Catheter infection and ventriculitis aren't exactly the same. And then anytime that you're going to take CSF out, you should do the gloves and the draping you clean it off exactly like you just said. Part 2 was you draw back 2 to 3 centimeters of CSF.
Milliliters.
Where milliliters of CSF. Where do you get this fluid from? Proximal, from the brain, right? You don't get it from the bag and from the line, because that is a #1 source of contaminant, right? And we have done that even in May and June of last year, right? Which is at the end of the year. You cannot take it from distal. You have to take it from proximal, which is from the brain itself.
Then, as I'd said, you push your drug, and the rate of the push will depend on what it is that you're administering. Generally, low and slow when you're pushing things into the brain. Then you flush the drug through the port with 1 cc of CSF. Again, as Dr. Muley said, it's CSF that you drew proximally. You maintain sterility during the procedure so that you put the patient's own CSF back to chase the medication down the tube. Then you remove your syringe, reapply ChloraPrep or alcohol to the access port, and then you cap the access port. Now they also have these nice green port caps called Curos that are chlorhexidine impregnated, and that also has been shown to decrease the rate of these catheter-based infections. Now, little pearls for intrathecal aspiration. Very little force is actually required to aspirate CSF in the majority of cases. If you need more than 1 cc of negative pressure, something is wrong. Either the ventricles are collapsed or the catheter fenestrations have flopped against brain parenchyma or the lining of the ventricle. And in this case, further pressure actually won't give you any more CSF. It'll just aspirate brain tissue. And for all of these labs and cultures, despite how lab might protest, you only need 2 milliliters of CSF for all of the tests that we order when we send our routine CSF labs. Any questions on EVD stuff? Okay. Now, moving on to subdural drains. These are indicated for the treatment of subacute or chronic subdural hematomas that are both symptomatic, meaning with altered mental status or a focal neurologic deficit, and greater than 1 centimeter in thickness. Now, to localize the bleed, you use a CT of the scan of the head. And although generally when you're doing neuroimaging, you prefer a gantry angle that's appropriate through the typical plane, one without a gantry angle or a gantry angle of 0 is preferred in the localization for a subdural drain. And in this case, you use the top of the pinna as your reference to measure where you plan to place your catheter. You measure your superior distance by counting the number of slices times the slice thickness. Typically, when you're looking at a trauma CT or standard ER CT, there'll be 5 millimeter slices, but occasionally you can see oddities like 3 millimeters, 6 millimeters, or 1 millimeter if you're doing thin cut CT heads. So make sure that you know what slice thickness it is you're looking at when you're counting so that you can measure it then appropriately. And then your anterior-posterior distance can be measured from the CT directly. Also, you can, yes, sir. Also, you potentially, depending on the sort of character of your subacute or chronic subdural, you can place the catheter superior to the temporalis muscle and anterior to the coronal suture. Yes, sir.
Go back to your previous slide for just a minute. So, are you referencing the greater than 1 centimeter from
This was from Greenberg.
So if you have a particular argument, let's say 5 millimeters, the patient's coming in for procedure.
No, certainly. Did I say and? I meant to say or. These are the or criteria.
Oh, what I'm saying is that really should be chronic is download. So you're not going to put one in if it's just liver or chronic subdural, but if subdural is causing trauma.
Sure, then you put in a subdural.
Maybe deficit. It's almost irrelevant.
Right.
So, I mean, the symptomatic part, if it's greater than 1 centimeter, maybe the patient needs to go on. Someone from 2 centimeters subdural, patient's not doing very well, and maybe they lost out on.
Right.
These are just, remember, what I'm getting at is, which you state, these are just some relative indications. It's not, so, like, for instance, interns of the US, don't automatically think that only 1 centimeter growth greater, but
Sure, that's absolutely true.
clarify that.
All right, now the procedure for placing your subdural drain, as always, follow your procedural musts. Mark your area of hematoma so that you know which side, approximately how big your hematoma is, where you plan to place the catheter. Again, clip your overlying hair with your surgical clippers. We don't shave for these procedures. Prep your scalp, again, using betadine or DuraPrep, not ChloraPrep in cases where you're violating Dura. Gown and glove, drape your patient. This, of course, assumes you've already mask. This, of course, assumes that you've already prepped your room and opened your tools. Again, you use lidocaine to create a skin wheel infiltrating down to bone, and you will also anesthetize the tunneling site as before. Again, make your vertical incision down to bone and scrape your periosteum off the calvarium using your preferred tool and method. In this case, you need to be careful to equip the correct drill bit. The EVD drill bit, the one that's included in the cranial access kit, is not sufficient to pass a mushroom tip catheter. If you're placing a trauma catheter to drain your subdural fluid, then sure, you can use that drill bit. However, if you're placing the mushroom tip catheter, use the drill bit that's included with the mushroom catheter. Once you drill your skull, use your forceps to remove your bone fragments. Again, make that same cruciate incision into the dura.
How do you drill it?
Or orthogonal to bone and orthogonal to brain tissue.
I think that's how we've had our most complications, if we drill it perpendicular. So I would drill it tangential.
Okay.
And when we had 4 or 5 complications in a row, we had a company come out and they said about orthogonal versus tangential. And the problems that we were having is we were drilling it perpendicular and we were putting the mushroom catheter into the brain itself. So although, depending on the literature you look at, it says says perpendicular, we've had the greatest amount of complications doing it that way. So do it tangential.
Okay.
Now, you don't do a big tangential hole because then you could shear off the mushroom. So it's not, so instead of maybe perpendicular 90 degrees, you do about 75 degrees. Okay? You don't want to go straight in. That's when we had our most number of complications. But you don't want to make a large tangential one because that's when it shears off the mushroom. So.
Okay.
Where did you get the information about perpendicular?
Perpendicular was from experience.
How many times did you put in the brain? 5?
I've been lucky. I've never put it in the brain.
Where's green? Does somebody have it? Look at it. Huh?
Doesn't talk about mushrooms.
Doesn't talk about bedside green.
Subdurals?
So
So what did they say?
They say perpendicular and use the right angle device.
So tangential.
Yeah, with the right angle device, I've actually been pretty successful. You reopen the original incision, remove the tip of the catheter with curved hemostat, cut the catheter and remove it from posterior, and you pull the tip of the mushroom out with your curved Kellys.
That works too.
Yeah.
But that's what the manufacturer says. But then that's when we had everybody place it right into the substance.
Got it. Okay.
I think the key is how deep you go when you're passing.
Yeah, go past the mushroom,
You're gonna go barely past the mushroom.
which is 2 centimeters.
That's that one.
To the end of the mushroom.
Yes.
That's big. Okay. Well, then you gotta go 1 centimeter.
But what you need to do is get to the end of the mushroom. But you can be starting to withdraw your stylet as you're pushing in. and you can push the catheter once you're in the subdural fluid and withdraw the silent once you're past the fluid.
Yeah, we just had so many numbers.
And I think obviously with the trauma catheter, you want to go injection because a trauma catheter has particular, you will get. I don't know that it's necessarily true.
Yeah, they did it. Absolutely.
I'm sure they did it. That's, I think.
I was going to just add something to that. You know, obviously, as a resident, I get a lot of support. Personally, I never had a problem, but I have noticed that it does have a tendency sometimes to it either irritates or so injections are always good, but instead I use Hammercam. But the key is I don't use the stylet at all. Because if you use the stylet, you're going to go into the brain, which is usually. So I have yet to ever see the Hammercam penetrate the brain specifically without the stylet, and that's the key. So you can't do that with the mushroom because you need the stylet to get the mushroom through, right? But you don't need it for the and as soon as most chronic subdurals have both neurosurgery and right? As soon as you go through the drill, you guys are going to see the fluid, right? So you know you're already inside. This all I do is put in whatever ventricular catheter you're going to use without the stylet. It goes in real easy. Won't penetrate. It's meant to be right, and it's less irritating. And that's my own question. The subdural rings work just fine, but I use that instead.
So you could see where you were saying about if the subdural is greater than a centimeter, then using the mushroom tip perpendicular would be okay because you wouldn't be putting it into the brain. But as Dr. Cortez said, and as you pointed out, it's a or, right? Because it's not only the amount of mental status changes, also the midline shift that might be associated with it as well. So if you can see, you're going to place a mushroom catheter in a subdural hematoma that's 8 millimeters. You're going to be 2 millimeters in the brain by the time you get this thing inside the skull. Right. So don't go perpendicular. Go tangential. And once we started doing that, we had 0 complications. We had 5 in a row. But anyway, we had many, and more than one is many. We had many in a row. But once we had the in-service, and the company came out and told us that, and then we said no. We started doing it tangential. We had 0 complications. That was the difference.
All right. So like Dr. Cortez alluded to, when you make your dural incision, you should get a return of motor oil colored fluid, and that's how you know that you are in a chronic subdural. You insert your catheter, whichever catheter you use, either the mushroom tip or the trauma catheter. You want to confirm that the catheter is in fact draining. Anytime you have this dural opening open to air, you want to make sure you have a 4x4 over the opening with some pressure. You don't want to create pneumocephalus during your procedure. Some people will advocate for sucking out fluid with a syringe and stopping immediately once resistance is felt. This can accomplish a couple of things. First, you can send the fluid for pathology if you suspect that there's anything subtending the subdural, and you also more immediately relieve the pressure from the subdural. Then you tunnel your catheter, confirm that it's still draining, hook up your bulb suction 5 centimeters away from the original incision. Or more. What?
Or more.
Oh yeah, no, or more. So then you hook up your bulb sucker and confirm that it's still draining. Close your incision with staples, secure your drain with a 2-0 suture and staples in your tension relieving coil that, again, as Dr. Mealy pointed out earlier, is extraordinarily important. Place your biopatch and your tegaderm to secure your system down. take down the drapes, make sure everything is still draining yet again, and check your pupils. Your being the patient's pupils, not your own pupils. Then in your post-op orders for this, you want a CT of the head without contrast stat. Again, you want to make sure that you haven't lacerated the brain or caused a brain contusion by placing this catheter. You want to make sure the catheter is in a space where it's going to continue to relieve fluid. If the catheter is sitting up against the subdural membrane, it may stop functioning, or it may in fact cause bleeding if you're pulling on that subdural membrane. Then you want to specify the amount of suction for your JP bulb to be under. Depending on the circumstance, it might be full suction, half suction, thumbprint suction, or even no suction, depending on what other drains you have in the brain. Again, ANSEF prophylactically, or if they're penallergic, you can use Vanco or whatever else they're on. Place the head of the bed flat, and it's okay to have the head of the bed up for meals, and have them turn the head side, middle, side every 2 hours. Yes, sir.
So what do you mean no suction?
So in some cases, I've seen where there might be another drain somewhere else in the brain, like an EVD or a parenchymal drain. You may want to have the bulb sucker attached to the drainage system so that it's still a closed system, and you allow the fluid to drip with gravity rather than yes, yeah. So no force suction, but you leave it to gravity. Yes, right. Okay, sorry. Right.
You have to be done.
Okay.
So you just tell us about this variation approach, and then we'll have to continue with the rest because you have a lot more, right?
Not a whole lot more.
But
Just
yeah,
lumbar punctures and lumbar drains are left.
We'll have to do it.
Okay. So then variations on these procedures, you can use trauma catheter, antibiotic impregnated catheter, barium impregnated catheter that shows up really nicely on imaging, or of course the good old mushroom catheter. You want to tunnel the catheter and close your incision before syringe suction because you want to prevent pneumocephalus. Again, the same concept behind putting the 4x4 on the original incision as you're manipulating stuff off of the brain, because pneumocephalus air in the brain is bad. So should I stop there and continue later? Okay.
All right, 4x4. That's
Mhm. Sing a song, Jerry.
How hard can this be?
Just a couple of things. So for the 4x4,
They can't hear you back on the hole.
The microphone won't project, that just records.
No.
Just talk louder.
let's do the 4x4 works best way. And also a second point of what the professor says in the trauma cap, the freehand, but if you choose to use solid, best as a minute is solid with a bit of hockey stick penalty. And when you insert it, you insert it right past the